Good evening, everybody. We welcome you in our Rehabilitation Academic Group with another session. Today we are having Dr. Amandeep Singh with us. Dr. Amandeep sir is professor and head in Department of Physiotherapy in Chandigarh University. Sir had did his PhD from the Punjabi University and Masters in Orthopedics from Dehradun. Sir is having 14 years of teaching experience, and Sir has the innumerous publication in the various national and international journals. And Sir is the renowned speaker in the national and international workshops and the conference. We welcome you, Aman sir, for giving us time. Thank you for sharing up knowledge. Sir would be taking up today's topic on physiotherapeutic challenges in ACL rehabilitation. Thank you, Dr. Aman. Thank you for giving us time.
Thank you, sir. Thank you. Good evening, everyone. I am, as Dr. Shagun sir has told, I am working in Chandigarh University and heading the Department of Physiotherapy. Today, I am going to discuss with you an topic on anterior cruciate ligament injury. What are the various challenges faced by our physiotherapy professionals while dealing with the injury of anterior cruciate ligament? Briefly about the introduction, about what is about the anatomy and functions of this ligament. This is one of the most important ligament of the knee joint, which is providing the anterior stability to the joint and made up of strong dense structures with connective tissue and connect bone to bone across joints, made up of collagen of multiple types, but mostly it is type 1 of collagen and is responsible, as I have already told you, that it is responsible for providing anterior posterior stability to the knee joint. Briefly, it is having about the anatomy. Anterior cruciate ligament has a mean length of 32 millimeters and width of 7.27 to 12 millimeter during full knee extension, and is innervated by a posterior articular branch of tibial nerve and vascularized by middle genicular artery. If we talk about the attachments, anterior cruciate ligaments begin from tibial fossa, anterior and lateral to the tibial spine, and runs upward and backward and laterally, and is attached to the posterior part of medial surface of lateral condyle. So it is like this is called cruciate ligament. It is crossing with the posterior cruciate ligament, as we can see from the diagram also, and it
Sir,
prevents.
Sorry to interpret, sir. You can share your screen, sir. Slide share. You can start slide share, sir.
Slide share is not working, sir.
Yes, sir. It's not coming on the screen. If you can start.
Is it coming, sir?
No, sir.
Because it is like shared from my side, sir.
Okay.
I think some.
Sir, you can slide. Have you slide shared?
Yeah, I am sharing it, sir.
From the below, the volume button.
I am sharing it, sir.
Okay.
And
just close and again reopen.
Okay,
sir,
okay.
Right? Again, restart, reshare, please.
Is it there now, sir?
Yes, sir.
Yes,
Yeah, now
there,
it is started, sir.
Share.
Yeah.
Right.
Slideshow. Start slideshow. Yes.
Now
Yes.
it's fine, sir?
Now
Yes,
it's
sir.
fine.
Now you. Yes, sir. Now it's
Now
fine.
it's fine.
Completely.
Yes,
Right,
sir.
right, sir.
Please go ahead, sir.
Now, anterior cruciate ligament is composed of principally two parts. Smaller one is anterior medial band, and larger one is posterolateral band, but it is bulky one in nature. And if we talk about the importance, anterior medial band is tight in flexion, and posterolateral band gets tight in extension. And in extension, both bands are parallel, but in flexion, both bands are crossed. Now, it is in this position that maximum time injury of anterior cruciate ligaments happens when the knee is in flexion, when it is in cross position. Now, it is ACL tear, one of the important ligament. And if we talk about the incidence of the injury of this ligament, there are approximately more than 100,000 cases reported in US alone each year. And is not a life-threatening condition, but it severely affects the ADLs, your activities of daily living, thereby hampering your quality of life. And because there is instability at knee joint, the patient complains of complains of anterior buckling of the knee. Patient, when he will be in weight-bearing position, the knee buckles forward. So that's why the patient's quality of life is not good. And the mechanism, if we talk about mechanism, it could be both contact injury as well as non-contact injury. Contact injury like direct blow on the ligament, and non-contact injury, there is no direct blow, but no direct contact between the two persons is there. And for this ligament to get injured, there is like combination of valgus and internal tibial rotation during landing causes this ACL to rupture. Like if valgus stress when combined with, again I'm stressing, valgus stress when combined with internal tibial rotation is going to cause this injury to the anterior cruciate ligament. Now, there are certain sports which are associated with the ACL tear, like the incidence of injury to anterior cruciate ligament is high in these, like alpine skiing is there, then soccer, American football, rugby, basketball, tennis. And in American football, there is like, due to much of the physical contact is there, the maximum incidence of anterior cruciate ligament injury is there in American football. There are certain athletic activities that are also causing this tear to happen, like hyperextension and pivoting injury of the knee. When the knee is in hyperextension and pivot type force is applied, then the injury happens. One step stop landing with the knee hyperextended. Then when like suddenly we are changing the direction while walking or running, it can lead to injury to the anterior cruciate. Then when you are running and suddenly stopping, it can lead to injury, because due to momentum of motion, the inertia of motion, the body, if stops suddenly, it is going to put a huge impact on the anterior cruciate ligament. Slowing down while running, then landing from jump or direct contact or collision, such as in football tackle. It can all cause injury to the anterior cruciate ligament. Now, if we are talking about severity or grading of this injury, we are dividing this injury into 3 grades. Grade 1, 2, 3. Grade 1 is mild injury with microscopic tear only, and ligaments get partially stretched with knee is in stable condition. Grade 2 is uncommon injury, means partial injury, moderate injury it is, but it is uncommon type, with the partially torn and knee joint becomes loose, bit of loose. And grade 3 is severe injury, in which the ACL is completely torn and the knee joint becomes highly unstable in that. Anterior cruciate ligament injuries hardly occurs alone, because the impact on the knee is such that the other structures are also getting involved in that. Like there is a small study which I have concluded that there is an incidence of associated medial meniscus injury in 50% of the cases, associated articular cartilage in 30%, and collateral ligament both medial more than lateral is 30%. If we talk about the signs and symptoms, the main sign, the main complaint patient is going to, he will complain that he has heard a popping sound inside knee. Then there is a patient's complaint of feeling of knee giving away, that the patient will feel the instability in the knee, that knee is not able to support the body weight. Then there is complaint of swelling, which may occur immediately after the injury or after a few hours. Then pain is there. Patient will complain of pain. If we talk about diagnosis of ACL tear, during the physical examination, we will check the signs like swelling will be there, tenderness will be there, and comparing the injured knee with uninjured knee, while we will be like checking the translatory motion between the two joint surfaces, then assessing the range of motion, overall function of the joint. These are all getting like affected with this injury. Often the diagnosis can be made on the basis of physical examination alone. Following special diagnostic tests are required to determine the severity of the injury. Like we apply anterior dot test, Lachman test, then pivot shift test. You must be aware of these tests, like the procedure of testing the anterior cruciate ligament with with these tests. Now there are role of diagnostic imaging while diagnosing the anterior cruciate ligament tear. Like X-rays, we will not be able to visualize the soft tissues, but the associated chip fracture that can happen with this injury, that can be ruled out with the X-rays. Then we can make use of diagnostic ultrasounds. Like you must be aware that we make use of sound waves to visualize the internal structures, and though it is not very much like we cannot find out the extent of the injury, but an impression can be like taken that whether any injury will be there of the ACL or not with the ultrasound. MRI is there. We make use of magnetic field to assess the injury at the ligament, and with this imaging tool, we can like assess the extent of the injury also. We can very well define what is the extent, whether it is grade 1, 2 or 3 tier. And then arthroscopy is there. It is minimally invasive procedure. It can be used as diagnostic as well as therapeutic tool. Means we can give treatment also while performing the arthroscopy, and we can assess the extent of the damage with this modality. Now, if the injury has happened, we all know the best treatment immediately after injury includes price treatment, price protection, then rest to the part, then ice, application of ice packs after maybe after each hourly or maybe after every 30 minutes, then compression using a compression bandage, and we need to elevate the part so that the incidence of swelling could be minimized. Then if we talk about management strategies, for managing the ACL tear, we can go for ACL reconstruction surgeries also. We can go for conservative management also. ACL reconstruction, first one is arthroscopic procedure. Again, as I have already told you, one is arthroscopic surgery, second one is reconstruction surgery. Indications for surgery includes like the patient if complains of disabling instability of the knee due to ACL deficiency, then if the patient complains of frequent episodes of knee buckling, like I have already told you that when the injury to knee joint ACL happens, the patient main complaint will be like the patient's knee joint becomes unstable. There will be anteriorly deficient knee. Then positive pivot shift test, because ACL is deficit is often associated with lesion of other structures also of the knee. Injury of the MCL is very common with the injury of anterior cruciate ligament, and high risk of re-injury because of participation in athletic events or recreational activities. These are all indications for surgery. Then first one is arthroscopy. Arthroscopy, as I have already told you, this is minimally invasive, can be used as both diagnostic as well as therapeutic, and the patient will be having the same day discharge from after the procedure. Then ACL reconstruction, it is a highly successful operation with good rehabilitation. 90 to 95% of the individuals can expect return to full sports participation within 6 months. ACL reconstruction involves using a graft which can be autograft, it can be allograft. Autograft, in this, the patient's the graft is taken from the patient's body, like patellar tendon is there, hamstring tendon, quadriceps tendon could be taken. Allograft is taken from the deceased, like the person who has expired. We can take the tendon from that person, like we can take patellar tendon, again Achilles tendon, semitendinosus, or other tendons. About the patellar tendon autograft, the middle third of the patellar tendon of the patient along with the bone plug from the shin and the patella is used in the patellar tendon autograft. It is recommended when the patient is like have to return to high level of athletic activity, or persons whose job doesn't require frequent amount of kneeling. Because we have taken the patellar tendon, the patient, if he is like getting involved in this position of kneeling, then it is going to be problematic. But it is like if we are taking the graft from the patient, it is having certain disadvantages also for the patient. Like patient will be experiencing post-operative patellofemoral pain with kneeling, increased risk of post-operative stiffness can be there because the surgery has been done, and due to like stitching done of the part, so it can lead to stiffness also. There is a risk of patellar fracture, as well as there can be weakness of the quadriceps tendon can be there. Quadriceps can be there. Hamstring tendon autograft, in hamstring semitendinosus part, which is lying on the medial side, is used to create graft is taken from that part of the tendon for use for ACL reconstruction. It is having again some disadvantages, like anterior knee pain is patient complains of after surgery. Then lesser post-operative stiffness problem can be there, but and smaller incision is there, and there is like limited by strength and type of fixation also there. Then quadriceps tendon autograft is there, used in cases where there is like who have failed ACL reconstruction prior, and this is also association with the post-operative anterior knee pain and low risk of patellar fracture. Then, as I have already told you, that we can take the graft from from other persons. In that case, the taken from cadavers and is becoming popular these days. And these grafts are also used for the patients who have failed ACL reconstruction, and is also used when more than one knee ligament has been injured. Like I have already told you that there is associated injury of ACL with the MCL, and it can be associated with the medial meniscus also. And there is the complaint of patient, like disadvantages I have already told you. In this case of allograft, the chances of that disadvantages is minimized by this allograft. Now there are certain complications are there when this like with the other surgeries only. The main complication of lower limb surgery involves deep vein thrombosis. Then there are chances of infection is there. Then stiffness can happen. Then graft impingement can be there, like, and excessive graft stress, sometimes it happens, it can lead to misalignment or malalignment of the graft is there, and the other generalized complications of associated with surgery are also there, like skin irritation will be there, and there will be difficulty in mobility also. If we talk about physiotherapeutic pre-operative rehabilitation before the surgery, the aim is to reduce swelling and restore full body mobility and strength, and duration is variable depending on the surgery date. The various techniques we can apply cold therapy, we can apply knee support using a brace, then mobility exercises to the joints, other joints of the leg, like both proximal as well as distal joints. Strengthening exercises can be given to the ipsilateral side. Then fitness training, taping we can use so that the patient can like move for his activities of daily living till the day of surgery. Now, when we go for post-surgical rehabilitation, there are certain principles which needs to be followed. First one and most important is which strengthening exercises should we follow, like open kinetic or closed kinetic chain. Early administration of open kinetic during the initial phase may lead to tear of the weak immature ACL, so is avoided. So these are the few things which need to be considered while we plan for the rehabilitation protocol for the patient. Then comprehensive lower extremity muscle strengthening and stretching exercises. Neuromuscular and proprioception training could need to be given. Then functional training, cardiovascular training. Then graded progression of the exercises should be done. Like depending on how the patient is responding to the exercise protocol, graded progression should be done. Then comes post-surgical rehabilitation. Phase one in the initial 2 weeks, the goal is like we need to define goal for each phase. Immediately after surgery, the goal is to decrease pain, post-operative swelling management, to establish initial 90 degrees range of motion. And with the, I have specially mentioned this, that we need to see that full extension should also be gained in this phase. Otherwise, it is going to be a problematic thing to establish full extension. Then patient re-education regarding gait, balance, and wound management. In this, we give range of motion exercises to using heel slides, then calf and hamstring passive stretches, exercise bike we can make use of in the initial phase, depending on the patient condition. Then we can make use of isometric exercises to quadriceps, to hamstrings, to gluteals, to and then we can make use depending on the patient status, we can go for we can start with isotonic exercises also in the partial range. Then gait training using crutches, gradual progress, we will start with making use of 2 crutches and gradually progressing to a single crutch. Then application of ice packs we can give, electrical stimulation we can make use of, proprioception training we can start in the initial phase, single leg weight bearing, both legs weight bearing, depending on the condition of the patient. Phase 2, in the initial 2 to 6 weeks after surgery, progress to full range, achieve normal gait pattern, strengthen opposite limbs, and progression should be done with the proprioception. Range of motion exercises we are going to progress for hamstrings. We can like prone assisted knee flexion and extension, then standing calf and hamstring stretches, assisted quadriceps stretching exercises, and heel slides and exercise bike we can make use of. For muscle strengthening, we can make you need to focus on quadriceps, hamstrings, then bridging, lying supine, then gluteus, calves, progress to single heel raise. Proprioception, we need to progress like double or single leg stance with the eyes closed as well as eyes forward and closed, then standing on half form roller and maintain balance. Gait training should be there. Progress to unassisted full weight bearing. Then cardiovascular, we make use of exercise bike, start elliptical trainer. Then in these phases we are going to progress to achieve full range of motion, and more strengthening exercises we have to make use of increasing the intensity or increasing the weight, so that proper strengthening could be done of the quadriceps, of these major muscle groups like quadriceps, hamstrings. Range of motion, we achieve full knee flexion extension, continue hamstrings and calf stretches. Then muscles, again we can progress to squats, lunges, then step ups, then eccentric lateral step downs, full wall squats. Isokinetic quadriceps rehabilitation program, we can start at this phase. Then hamstring bridging using Swiss ball. Then gluteals, we can make use of ankle weights or resistance cables to strengthen the gluteals. Then calf muscles, then proprioception, we can progress to single leg stance on minute, we can on mini trampoline. Then upper body work, then floor disc squatting, wobble board, gait, hydrotherapy, we can make use of. Then cardiovascular training, for cardiovascular training we can make use of exercise bike, swimming, pool jogging, treadmill. Then in the next phase, phase 4, then continuing stretches as before, and then increasing the strengthening program, like dynamic lunges, backward step ups, then eccentric step down, single leg squats, then hamstring curls, gluteals, calves, strengthening program. Then proprioception, like catch, we can again progression is there, like we can progress to catching or throwing exercises on wobble board or mini trampoline. Then single leg stance on floor disc, then cardiovascular pool running, exercise bike, treadmill for cardiovascular. Then similarly we can progress depending on the condition of the patient. We can make use of ladder drills, side step overs, skipping and hopping, then mini trampoline, continue single leg floor disc exercises. Then for cardiovascular, pool hopping and squat jumping, jogging, treadmill, sports specific cardio training. Then in the sixth phase, almost 6 months after the 4 to 6 months after the surgery, we can start with sports specific lower chain strengthening and progress to plyometrics, and continue proprioceptive as well as for cardiovascular fitness, like progress on mini trampoline. We can increase the hardship of the exercise. Then forward and side hops, then cutting drills and ladder drills in all directions, single leg forward and side hopping, single leg jumps, single leg drop landing. Then for cardiovascular, we can increase the intensities of all the exercises, jogging with few activities like turns at 90 degree, 180 degree, then jogging and cutting with 45 degrees of change of direction. Outdoor cycling we can make use of, swimming we can go for. Phase 7, 6 to 9 months after the surgery, adequate cardiovascular fitness has been gained, strength, power, neuromuscular control has been gained. Then continue with upper body strengthening, back to sports practice for upper skills, and return to sports skill on, add practice with minimal risk of re-injury. Few of the exercise suggestions are there, like single leg drop jump with 6-inch height step, then large figure of eights. Karaoke running we can make use of, like it is a sideways running involving the hip rotation, and 2 and 1 foot hopping with control. It involves like repeated hopping with knee flexion and extension, then triple jump, single limb drop jump. Then this is a small criteria about returning to work. If the job involves sitting down job is there, the patient can resume the work after a week or so after the surgery. And if the job requires standing, it may take 4 to 6 weeks before the return is recommended. And if it requires lifting moderate loads or climbing activities, recovery time may need to be as long as 2 to 4 months. If we talk about conservative management, if the knee stability can be controlled by avoiding activities that the individual doesn't mind avoiding, then conservative management is the preferred one. When the clinical diagnosis of ACL tear is made and the patient opts for an arthroscopy should be performed just to assess the associated injury and to wash out any hemarthrosis, then assess and treat other injuries such as meniscal tear. Associated, I've already told you that meniscal tear, collateral ligament, articular damage is very commonly affected with the injury to the ACL. The rehabilitation program for conservatively managed ACL injury is similar to the one after reconstruction. The principles include reduction of pain and swelling, restoration of full range of motion, then increase of muscle strength and power, functional restoration, then return to sports or work. We can make use of knee braces to provide stability, and the effectiveness of these braces varies depending on the degree of instability and the type of the brace. Depending on the degree of instability and other associated abnormalities, the rate of progress in patients with conservative management, it may be slow or fast than after a reconstruction surgery. And conservative treatment of ACL injuries is most successful in sports that are not dependent on jumping or pivoting motions. Thank you.
थैंक यू अमन सर, आपने टॉपिक को बहुत ही सिंपल बना दिया है ना। जो इतना एसीएल रिकंस्ट्रक्शन और एसीएल के ऊपर इतना कुछ डिस्कशन होता रहता है, और वो बहुत ही आपने सिंप्लीफाइड वे में आपने इतना अच्छे से समझा दिया। सर बस कुछ थोड़े से क्वेश्चंस मैं जानना चाह रहा था जो स्टूडेंट्स के थे। सर तो अगर हम बात करें तो अप टू द ग्रेड 2 इंजरी, if it is up to grade 2 injury is there, then the athlete or the patient should go for the conservative management?
Yes, sir. If they are not like their work doesn't require any, like if the person is in athletic activity, in gymnastics, then definitely they should go for opt for this surgical management, reconstruction surgery. But if it is like they are not into such kind of activity, they should opt for conservative management only. Because if it is a because it is like a lot of complications can be there of surgeries, so it will be better if that person goes for conservative management.
So sometimes our athletes got feared कि सर ACL इंजरी हो गया तो अब मैं वापस शायद ना खेल पाऊं, तो क्या ऐसा कुछ मिथ है या क्या है ये?
सर मेरे पावर पॉइंट में वो सबसे पहले मैंने लाइन लिखी थी, if that athlete after a reconstruction surgeries undertake the complete rehabilitation protocol, there is a chance of 90 to 95% that the person is going to come back to his previous activity level.
Previous activity. तो मतलब कि हम सारे फिजियोज ये कहें कि हमारा फिजियोथेरेपी से the athlete would be able to return to their sports level. बिल्कुल कि वो अपना वो कर पाए. Sir, one more thing was there. आजकल isokinetic exercises and the balance trainer ये सब बहुत आ गए हैं. तो कई बार क्या होता है कि मैं एक वो देख रहा हूँ कि बहुत ज्यादा स्पोर्ट्स क्लिनिक खुलने की बात हो रही है. तो क्या आपको लगता है कि बिल्कुल जरूरी है या हम नॉर्मल क्लिनिक पे भी ACL रिकंस्ट्रक्शन को
सर नॉर्मल क्लिनिक्स में किया जा सकता है, लाइक जैसे हमने इसमें ट्रैम्पोलिन वगैरह का यूज करके या इस पूल एक्टिविटीज को इन्वॉल्व करके हम डेफिनेटली उसका कर सकते हैं सर। पर जो आइसोकिनेटिक के साथ, जी जी सर।
हाँ, क्योंकि सर समटाइम्स सर आपको पता है आइसोकाइनेटिक की कॉस्ट बहुत ज्यादा हो जाती
बिल्कुल
है
बिल्कुल सर।
एंड इन द क्लिनिक बिल्कुल उस पे कर रहे हैं, तो विद द आवर एक्सरसाइज आल्सो वी कैन गो फॉर दिस
यस
थिंग।
यस सर, वी कैन इजीली गो फॉर इट सर।
डॉक्टर धर्म, अगर आप कुछ और क्वेश्चंस हो पूछना चाहें।
नहीं सर ने तो बड़ा अच्छे से सारा कुछ इतना ऐसे आसान बना के सबको बताया, सो मुझे नहीं लगता कि अब फर्दर क्वेश्चन की जरूरत ही है, इतने अच्छे से सबको समझ आ गया। सो बाकी अब कोई ऑडियंस की तरफ से कोई क्वेश्चन हो तो दे कैन पुट दैट, एंड इफ
सर
नॉट वी कैन
डेफिनेटली
वाइंड
सर,
अप द
अमन सर
क्वेश्चन।
आपकी इतनी अच्छी एक्सरसाइजेस थी, मैं चाहूंगा कि आपका नेक्स्ट लेक्चर सर प्लायोमेट्रिक्स एक्सरसाइज और जो आपने इतनी सारी ड्रिल्स बनाई है ना, बताई है, उसके ऊपर एक रखा जाए जिससे कि
श्योर
स्टूडेंट्स को
सर,
पूरा वो एक्सरसाइजेस हम उस पर कर सके।
अगर मैं
काफी
उनको
सारे
एक्सप्लेन
बच्चों
करना चाहता था सर, बट ड्यू टू टाइम लिमिटेशन वो अपने आप में एक
या
बहुत बड़ा टॉपिक है सर।
बहुत बड़ा टॉपिक है। नहीं सर, क्योंकि काफी स्टूडेंट्स की आ रही है कि सर हम लोग जो सीखना चाहते हैं, जो
जी जी
आपने
जी,
ड्रिल्स बताई हैं 8 इंचेस 6 इंचेस पे, कि उन्हें कैसे किया जाए, तो मैं
बिल्कुल
उसका
बिल्कुल
आंसर
सर।
वही लिख रहा हूं उनको कि जैसे ही हमको नेक्स्ट आपके लेक्चर का वो मिलेगा तो हम उसी चीज में करेंगे कि कैसे अब इन एक्सरसाइजेस को करना है पूरा।
श्योर सर श्योर।
ये बिल्कुल डेफिनेटली हम लोग
बिल्कुल
और आगे आपसे जुड़े रहेंगे, और विद दिस नोट मेरे ख्याल से हम कंक्लूड कर सकते हैं
जी
सेशन
सर,
को। और इसके लिए बहुत थैंक यू आपको डॉक्टर
वेलकम
अमनदीप,
सर।
क्योंकि आपने समय निकाला रिहेबिलिटेशन साइंसेज ग्रुप के लिए, और पीपल आर गेटिंग बेनिफिटेड विद दैट। So with this note, we are concluding this session today, and at the last, I do request everyone to please subscribe this channel so that you keep getting updated with the next lecture. You get notification. So thank you, Dr. Sab. Thank you so much. And with this note, we are closing this session round. Thank you.
थैंक यू वेरी
थैंक यू
मच सर,
सर,
थैंक यू
थैंक यू, थैंक यू
फॉर दिस अपॉर्चुनिटी सर, थैंक यू वेरी मच सर।
थैंक यू डॉक्टर साहब, थैंक यू।